Hello, my name is Med2Med. Today's notes are going to be on a pneumothorax. These notes are made with the use of these very helpful resources I've listed here. We have scotsnotes.co.uk, a really good PDF online of all different kinds of medical notes used to pass the finals. I've got Oxford Handbook of Clinical Medicine, which is my go-to Bible. We've then got the nice guidelines and geeky medics. As a disclaimer, I am a third-year medical student. This information is not intended to be a substitute for professional medical advice, and you should always consult your doctor. So, to begin with, what exactly is a pneumothorax? Well, here you can see an image of a collapsed lung with air or fluid in the pleural space. This collapsed lung is called a telangiectasis, but this air or fluid in the pleural space is the pneumothorax. So, a pneumothorax is a collection of air between the parietal and visceral pleura. Now, if you remember, you can see on this image, the parietal pleura is the outer lining and the visceral pleura is the inner lining. We can remember this because visceral means inward feelings and parietal means wall. You can split the pneumothoraces into two categories. We have primary and secondary, and this is all relating to the causes of the pneumothorax. Primary means without underlying disease. Often you get this spontaneous pleural bullae rupture that's often seen in tall, thin young men. You've then got secondary pneumothoraces, which are as a result of underlying disease. Sometimes it could be due to asthma, COPD, infections such as TB, a lung abscess, carcinoma, sarcoids. You could also have Marfan's disease, connective tissue disorders. This, of course, can also be iatrogenic, so as a result of a pleural aspiration, a liver biopsy, or positive pressure ventilation. Of course, it can be due to trauma. If there is blunt trauma to the ribs, this may cause a puncture within the pleura. But the most important thing out of all this information is to take a good history so we have a good understanding of what has caused this pneumothorax. Most patients present with these two symptoms: dyspnea, which is breathlessness, and pleuritic chest pain, which is a type of chest pain that occurs when you inhale. When we look at a patient with a pneumothorax, we expect to find different signs on examination. Firstly, you may notice that they have reduced expansion where the pneumothorax is. It may be hyperresonant when you percuss it. You may notice that there are reduced breath sounds when you hold it over the location of the pneumothorax. And in some cases, you may even notice that the trachea is deviated. This is a medical emergency and is a result of a tension pneumothorax. These may not be the only things you find. In fact, we've got some more generalised symptoms such as a raised JVP, a fast heart rate, and low blood pressure. You can also categorise pneumothoraces as closed, open, or tension. Closed meaning an intact chest wall, open meaning there is a chest wall defect, and a tension pneumothorax, as we've spoken about, which is air entry to the pleural cavity. This is in one direction only. We now know that a tension pneumothorax is a medical emergency because if untreated it can result in respiratory distress or even a cardiac arrest. Because this condition is so serious, it means that we can manage it or investigate the condition in different ways. The most important thing to remember is you do not perform a chest x-ray if you suspect a tension pneumothorax because this is delaying treatment. However, if you are happy that this is not a tension pneumothorax, you may progress with an ABG if the patient has low oxygen, but the gold standard is a chest x-ray. You might even specifically request an expiratory film. Here we can see a chest x-ray with a pneumothorax on the right hand side. This is circled in this zone here. You can see absence of normal lung markings, but there is no tracheal deviation, which means this is not a tension pneumothorax. If you look closely at this x-ray, however, you may notice that you can see the trachea has deviated slightly and has shifted the mediastinum. On the left-hand side, there is a pneumothorax. However, this X-ray should not happen. As we know, this is a medical emergency and chest X-ray should not be carried out. Now we can move on to treatment. For a tension pneumothorax, it is important that the most immediate thing you do is a needle decompression. This is done in the second intercostal space in the midclavicular line. Remember, you also have to work through your ABCs. You may need to resuscitate the patient. Now we've looked into the immediate treatment for a tension pneumothorax. In some cases, you may do an aspiration. For instance, if the patient is symptomatic, if there is a large primary pneumothorax, remember that means there is absence of underlying disease, or if there is a secondary pneumothorax, and that can be small in size. But if we have a small primary pneumothorax, we may not need to aspirate. In some cases, a chest drain is even necessary. For instance, if you have tried to aspirate the pneumothorax and there has been no improvement, you'd move on to this option. If there's a large secondary pneumothorax, you may also choose this, and this is required post-needle decompression for a tension pneumothorax. For most people, once the pneumothorax is treated, the condition resolves and it doesn't occur again. However, for a small population of people, they can indeed get recurring pneumothoraces. In these cases, it may be necessary to consider more advanced treatment to prevent it happening in the future. One particular type of treatment is called pleurodesis, and this is where you take the lung and adhere it to the chest wall. You no longer have a pleural space, so it reduces the likelihood of another pneumothorax occurring. Now there's a lot of information to take away here, but there are some key points that I have highlighted. First, you must remember the definition of the pneumothorax, which is that it is an abnormal collection of air within the pleural space. When we think about how our patients might present, they often have one-sided chest pain and breathlessness. History taking is so important. We have to determine whether this is a primary or secondary pneumothorax. Is there an underlying disease? You should never do a chest X-ray if you think it's a tension pneumothorax, because this is a medical emergency. The first line of treatment is aspiration and then draining. As usual, we do an A to E assessment for everything. Do not miss anything. And if it reoccurs, consider pleurodesis.